Hey, good evening. So my name is Carrie Smith. Today is February 16th, 2020, and I have prepared a PowerPoint for a GI project for my Nursing 2 class. The topic that we're going to be discussing this evening is GERD, gastroesophageal reflux disease. Just a couple of things that you may or may not know before we get started. So GERD affects 60 million Americans. It was originally thought to be a disease that only affected white men over 50, but with advances in medicine, we now know that it affects all races, age groups, genders, social, economic classes. The most common symptom of GERD is heartburn. Lots of patients will complain of a burning behind their chest, among other common signs and symptoms. Some not so common signs and symptoms include sinus pain and headache. They are rare, but they can be some surprising signs and symptoms. So GERD can permanently damage the inner lining of your esophagus, leading to a condition called Barrett's esophagus, and left untreated, Barrett's esophagus can lead to esophageal cancer. So even though GERD starts in the stomach, it often doesn't involve food. So in this PowerPoint video, we are going to take a look at several risk factors and potential causes of GERD. Treatment is available for patients suffering with GERD, and it has proven to be quite helpful. Treatment involves medication, surgery, lifestyle changes. There are several things that the patient can do themselves to kind of help alleviate their GERD symptoms, such as sleeping on their left side when they go to sleep. So stomach acids and gastric juices aren't allowed to flow back up into the esophagus. Also, chewing gum after meals helps because that promotes swallowing, and swallowing helps reduce reflux. So without further ado, let's get started. So here on the first slide, it just shows you that we're going to be talking about GERD today. My name and my Nursing 2 class is what we're doing this project for. So what is GERD? So GERD occurs when stomach acid is frequently allowed to flow back into the esophagus. Mild acid reflux that occurs twice per week, or moderate to severe acid reflux that occurs once a week. Like I said previously, this acid reflux can irritate the lining of the esophagus. So these events are most common in the postprandial state. This position allows allows reflux of gastric acid when the lower esophageal sphincter is relaxed. Like I stated previously, it does occur in all age groups and affects roughly 20% of the population. That does make GERD one of the most common upper GI problems seen in adults. Okay, so here's just some pathophysiology of GERD. It just kind of shows some different causes and factors for developing a GERD diagnosis. So what causes GERD? GERD is frequent acid reflux caused by inappropriate relaxation of that lower esophageal sphincter in response to an unknown stimulus. So when you swallow, the lower esophageal sphincter relaxes to let food and drinks move into your stomach, and then it closes again. If that sphincter relaxes abnormally, stomach acid can flow back into your esophagus. And the constant backwash of acid irritates the esophagus, often causing it to become inflamed. So some clinical manifestations. Irritation of chronic reflux is the primary symptom. So pyrosis, which is heartburn, it's often described as substernal or retrosternal burning sensation. Regurgitation is also another thing that is seen. Patients may experience feeling a warm fluid moving up their throat, and they may also experience a sour taste in their mouth. Symptoms can include dry cough, feeling a lump in their throat, dysphagia, and hoarseness or sore throat. GERD can also produce belching and feeling of flatulence. So the severity of the reflux episode typically determines the severity of the signs and symptoms. So the worse the episode is, the worse the signs and symptoms are going to be. More frequent and severe episodes of GERDs can trigger asthma attacks, cause severe chest pain, result in bleeding, or promote a narrowing chronic irritation of the esophagus. Nursing assessments. So some subjective data that you may gather includes heartburn that may radiate to the back or the jaw, and in some cases it can mimic angina, regurgitation, a sour bitter taste, flatulence, sore throat, nausea, odonophagia, which is painful swallowing, and dysphagia. Objective data includes a nocturnal cough, wheezing, hoarseness, damaged teeth from the stomach acid, and bad breath and vomiting. Okay, so diagnostic tests. There's a couple of tests that they can do to help diagnose this. An esophageal pH test is where the patient is fitted with a small nasogastric tube. It remains in place and is connected to a computer that the patient can either wear on their belt, or they can use a shoulder strap to carry that around with them, and that stays in place for 24 to 48 hours. This test is typically done in conjunction with an esophageal motility test or a Bernstein test, and those to evaluate the competence of that lower esophageal sphincter. There's a video there that talks about that esophageal pH test that you can feel free to watch while you're viewing the PowerPoint. Another test that is done, typically an endoscopy is performed to routinely evaluate the lower esophageal sphincter competence. It can also detect scarring or strictures and the presence and severity of esophagitis, and to rule out any malignancies. And there's also a video attached for that test. Okay, so some medical management. First of all, we're going to start with pharmacological therapy. Medication therapy focuses on improving the lower esophageal sphincter function, increasing esophageal clearance, and decreasing the volume and acidity of the reflux, and protecting the esophageal mucosa. So treatment with antacids. So just mild acid reflux you can treat with over-the-counter antacids, Zantac, Pepcid, things of that nature. In more severe cases of GERD, your physician may prescribe a proton pump inhibitor such as Prilosec or Nexium to reduce stomach acids. Other medications used are anti-ulcer medications or promobility agents, and that the promobility agents increase peristalsis, prompting gastric emptying. So some surgical intervention. There's a couple of different surgical treatments. So the first one is a niacin fundoplication. It's a surgical procedure that can be performed to strengthen the lower esophageal sphincter. There's a video of that procedure attached as well. There's also a stretta procedure that uses electrodes to heat the tissues in the esophagus to create scar tissue that strengthens the esophagus. There wasn't a great video of that, so I didn't attach one just because I didn't want to cause any confusion. There's another procedure that's done fairly often, and it's a fairly new procedure. It was just approved in 2012. And it is quite a bit less invasive. And what that entails is it's a band of magnetic titanium beads and those are implanted around the lower esophageal sphincter, and then it strengthens it by closing the sphincter when it's necessary. I've attached another video just for fun. It's a animated video that kind of shows the process from start to finish of your GERD diagnosis. Patient teaching and nursing interventions. First of all, you want to teach your patient about lifestyle changes, just simple things that they can do to help alleviate some of these symptoms from GERD, from things like changing their diet to a low-fat, high-protein diet, reduce any caffeine intake that they may have, remaining upright 1 to 2 hours after eating. So there's several things there that the patients can do to help alleviate some of those symptoms on their own, in conjunction with things that their physician is doing. So more patient teaching and interventions. Patients who smoke should be encouraged to quit. The tobacco actually relaxes that lower esophageal sphincter and can help in the cause of stomach acids being allowed to flow back up into the esophagus. Teach patients to avoid tight constrictive clothing over the abdomen. They need to avoid activities that involve straining, heavy lifting, or working in bent over positions. Patients should be instructed to never sleep flat in the bed. They can elevate the bed 6 to 8 inches by using wooden blocks or foam wedges. However, they do want to be careful elevating the head of their bed too much, as that can lead to neck and back problems. So prognosis. If GERD is controlled, if GERD is not controlled, it can progress to a serious, even life-threatening problems. We talked about the Barrett's esophagus earlier, and if that's left untreated, it can lead to esophageal cancer. Esophageal ulceration and hemorrhage can result from severe erosion. Chronic nighttime reflux is accompanied by significant risk of aspiration. Adenocarcinoma can develop from the premalignant tissue, that's the Barrett's esophagus, and scarring can permanently damage the esophageal tissue and produce strictures. I believe that is all I have for you this evening. I hope you guys have enjoyed and learned something.